Okay, good morning everyone. My name is Simon. I work in health services here on the campus. I'm a registered nurse. I graduated this program last May of 2012. I work at Nassau University Medical Center on a surgical floor, so pre-op, post-op. Every once in a while we'll get a medicine patient, you know, but usually they're traumas or, like I said earlier, pre-ops or post-ops. In any case, two things for today. Health services. We're located in the Medical Arts Building, room MC02. That's the basement, for those of you who don't know. Services we offer: blood pressure screening, cholesterol screening, glucose screening, and that'll fit in later in the lecture. Also, I'm quite excited about a new service that we are offering, pregnancy screening. Unfortunately, it's only for one sex, the female. Okay, that went over the head. Also, if you ever have any questions with regard to counseling, maybe not so much psych issues, but health questions, feel free to stop on by. We have 3 registered nurses. We used to have 1, and we have 3. We're open 9 to 5, depending on the day. Always check our website, www.qcc.cuny.edu/health services. Anyway, any questions with regard to health services and the services we offer? Yes? No? Going once? Going twice? Okay. Yes? Yes. Floor is all yours. Oh. Yes. Any questions with regard to the nursing program should be reserved for Professor Alex Tarasco. Any questions for health services? Immunizations? Anything?
When you get your paper sometimes from Marianne or from me, it says you can't register yet because you don't have your immunization papers figured out. You have to go to health services, okay? We don't do it for you. You have to go there and get a signature and get the form. Okay, so that's another thing that's really important in health services for all students.
Yes, all students. Unless you're a visiting student. No? That's it? Yeah, okay. Alrighty. So I guess we can jump right into it. As a side note, talking about diabetes, can every other person in this room just raise your hand? Every other. Okay. Okay.
That's good. So not next to you, but the person who's next to the person next to you.
Yes.
Raise your hand. Raise your hand, please. Purple sweat. Raise your hand. Keep yours down. Okay. See what every other means? Not everyone, but half.
Okay. Let's try it another way. This side of the room, raise your hands. Just one hand. It's okay. You won't get in trouble. Raise a hand. You'll like this activity, I promise. All right, keep it up, keep it up. There's a point to this, I swear. All right, yes, let's stand up. This side of the room, stand up. Don't be scared, it's okay. There we go. See? Fairly easy, fairly. Okay. Let's say this group of people, everybody look at them. This group of people represents 1/4 of this room. Yeah, you know, roughly speaking. This group of people will have diabetes. How do you feel about that? Yeah, okay. I guess you didn't get that one either. That's okay. Anyway, the idea is about 1/4 of the population, well, you can sit down, I'm sorry. About 1/4 of the population of the United States. Yeah. One at a time, I forget. About 1/4 of the population of the United States is either suffering from diabetes or will suffer from diabetes. The idea behind this little presentation here is that there are certain lifestyle changes that you can take or make, or whatever verb you want to use, to prolong or even, what's the word I'm looking for? Prevent diabetes. Well, in any case. Okay. Diabetes mellitus type 1 and 2, understanding treatments and complications. There's no real mystery with regard to diabetes mellitus. Well, maybe in the laboratory setting, but practically speaking, there is no mystery. Work with me, 1 second, please. Anyone really good with computers? Oh. Oh, very nice. Who said that? Very nice. Thank you. Thank you. Anyway, this is the main screen. Okay. So, historically speaking, diabetes has been around for a pretty long time. This Greek man, Horatius of Cappadocia, or Cappadocia, depending on where you're from, around the 1st century AD, was a guy, a physician, who saw in his patients excessive urination. He couldn't figure out why. Now get this. Back then, they used to do a lot of weird things. At one point, he actually tasted the urine of one of his patients, and it was sweet. Yeah. Don't be doing that, but I'll get back to why it was sweet. So he termed this condition, it's a Greek word. Now, pardon me, I'm not Greek. Oops. Sorry. Ooh. Sorry. Bear with me. Oh. Catastrophe averted. He termed this particular condition of sweet urine diabetes. Alrighty, essentially what it means is to pass through. To pass through what? We suspect they knew what the kidneys were, to pass through the kidneys. So he had these people who were essentially creating lots and lots and lots of sweet urine. Fast forwarding several hundred years, we have Paul Langerhans. He was a histologist, really smart guy. Actually, if I had a time machine, he'd be one of the people that I'd like to meet. He was essentially sitting around one day working on his, what we would call a doctorate degree. Well, for his time, 1847. So, mid-19th century. He was sitting around looking through his microscope, and he was looking at the pancreas. I always forget. It's either rats or pigs or some kind of filthy animal. He was looking at these pancreases, and he noticed that there were peculiar-looking globs of cells. So essentially, sometime later, another two people, also, I forget their name, they termed those islets the islets of Langerhans. Now, essentially, the term islet just means to that little collection of cells. Okay. Etiology. Etiology, it's just a fancy word that means, where does it come from? So, whenever you go to your doctor, he'll give you, let's say you're going to a doctor for the first time. He'll say, hi, my name is Dr. Whatever, and you're patient so-and-so. Tell me about your family. Who's sick, and what do they have? So there's a strong predisposition to diabetes secondary to the family members that have diabetes mellitus. For example, mom and dad have diabetes. You have an 80% chance of attaining diabetes sometime in your life. Pancreatic trauma, all that means is, let's say you were in a car accident and you went flying into the windshield. Hurting the pancreas essentially damage it to the extent where it decreases its ability to secrete insulin. And we'll get back to what insulin means to us. Pancreatic disease, for example, pancreatic cancer, Not that you'll have to worry about diabetes. More than likely you'll be 6 feet under the ground with pancreatic cancer, but that's another story for another lecture. Obesity, or just being overweight. There's a strong correlation with overweight individuals who have diabetes. What do I mean by that? The higher your weight, or the more you weigh, the greater likelihood that you'll develop diabetes sometime in your life. Actually, the most recent study that I've read, anything 7 to 10 pounds over your preferred body weight. So let's say if I'm supposed to weigh 150 pounds, which I don't, and I weigh 160 or 162, my chances of diabetes increase. Impaired glucose tolerance, another fancy term which means I'm unable to tolerate glucose. So I'll have a sugary snack and my blood sugar increases as opposed to decreases. Impaired fasting glucose. You'll go to your doctor, he'll take a little sample of blood, and your sugar's high. He'll ask you, when was the last time you ate? 3 hours ago. Sugar shouldn't be high. Ethnic background. Depending on your ethnicity, ironically, your likelihood for diabetes is greater. For example, Afro-American individuals have a greater likelihood of having diabetes than, for example, Caucasians. Second in line, Asian Americans. Sedentary lifestyle. The old adage of, an apple a day keeps the doctor away. There's some truth to that. But in modern time, especially the fact that we're completely glued to the computer and any sort of television screen really holds water with regard to those individuals that don't move around enough, lay speaking, also have an increased chance for getting diabetes. So just keep these things in mind. It'll all make sense later. Gestational diabetes, it's just something that comes around, it may or may not, when you're pregnant. Again, this is for the ladies. Age. I don't really like the whole age idea because you can be born a diabetic or you can be 92 years old and develop diabetes. There's no real correlation there. And environment. For example, if I'm living next to a power station and I develop pancreatic cancer, the environment caused my pancreatic cancer, which caused my diabetes. Epidemiology, another fancy term which means what's going on, who's being affected, and how. You can go onto the census.gov website, some pretty cool statistics there. I'm not really fond of statistics, only because they change on a day-to-day basis. But on the whole, about 8.3% of the population, of the US population that is, has diabetes. Okay, it's a monstrously expensive disease to treat. But again, that's for another lecture. It's the 7th leading cause of death. Now again, you don't necessarily die from diabetes. You die from what diabetes causes: strokes, heart attacks. Actually, if your sugar's too high, very often what happens is they go into something called a Diabetic Ketoacidosis. It's actually quite entertaining. I saw someone go into that once. But we saved him. But essentially your sugar becomes so high, you pretty much turn into a big ball of acid. It's really interesting. If you ever want to read up on it, it's quite interesting. Kidney disease, nervous system disorders, all this, it'll tie in. Okay, very basic anatomy and physiology. So here we have specimen A. So we start eating through the mouth, naturally. We'll chew, and all of our food goes down this tube. It is called the esophagus. The esophagus essentially empties out into the stomach. It gets churned around, some chemicals get added, nice stuff. There are certain chemicals that are released in the stomach which signal the pancreas to start releasing insulin, which is a normal thing. Our our cells, they'll sense that sugar, let's call it sugar, has entered our system. Insulin gets secreted in order to decrease blood sugar levels later on in the digestive system. Okay? And again, insulin is produced in the pancreas. Okay? Here's just an up-close and personal view. The liver, it's quite large. It's in the right upper portion of our bellies. And the pancreas is pretty much right below midline. Okay? It is beneath the stomach. It's one of those organs you don't really feel that it's there until the very end. Yeah, very often what happens with pancreatic cancer. You'll notice I refer to pancreatic cancer. It's actually my third favorite disease. In any case, here we have the pancreas. It's not actually this large. It's quite small. It's about 7 inches long and about 2 to 3 inches wide. It secretes insulin straight into our small intestines, which gets mixed with the food, and blood sugar levels go down, but later on in the digestive tract. Okay, so when we talk about diabetes and how do we screen for it, you'll go to your doctor and say, you know what, doc, I haven't been feeling too good lately, you know. And the doctor says, okay, it's your first time. Let's see what's cooking, so to speak. There's something called an impaired glucose tolerance. Essentially what we do, you'll see these interesting looking drinks. They're quite unappealing to the taste. Imagine Coca-Cola 50 times sweeter. It's quite putrid, actually. So you'll drink this stuff, about 1 bottle, and 2 hours later we'll take a sample of your sugar and we'll see how high your blood sugar is. If it's high, you probably don't have diabetes, but if you come in for a second time and we run the same test and your sugar's high, you probably do have diabetes. Now, there are essentially 2 types of diabetes. Really, there are 4, but let's focus on what we all know and all hear in the news, type 1, type 2. Type 1, usually it'll be this man, quite skinny, doesn't really look like anything, just a skinny guy walking around. This guy has type 1 diabetes. What does that mean essentially? He or she, but in the picture it's a man, is unable to produce insulin. These individuals are more likely to die from the condition that I told you about, diabetic ketoacidosis, unless they are treated. Essentially, they die within several hours, you know, without treatment. The main, I guess, pathophysiology, which is a fancy term for disease process, to destruction of pancreatic cells that produce the insulin is unknown. You know, there's some anecdotal evidence that viruses may be involved. Personally speaking, I think it's an environmental factor. Or you're just susceptible to it because of some degenerated genes that happen to be passed down along the genial line. In any case, there's very little insulin that is being produced, and over the years, no insulin is produced, whereby the individual becomes dependent on insulin. And I'll cover that as well as we go along. Type 1 diabetes. Symptoms: hyperglycemia, which essentially just means high sugar levels. There's a funny term. It's actually, Professor Tarasco, I'm sure you know it. I learned it here. The 3 Ps of diabetes: polyuria, polydipsia, and polyphagia. Poly essentially means a lot of something. Uria, which refers to urine, a lot of urine production. Polydipsia, dipsia referring to drinking. Individuals more often than not are quite thirsty, to the point where they're drinking not just 1 or 2 glasses, but maybe 10 to 20 glasses of water, which is futile to begin with, but you know, it'll all tie along, I promise. And polyphagia, they become excessively hungry. Now, the mechanisms behind all three of these are markedly complex, and you can spend years talking about each one of them. But on the whole, these individuals are very thirsty, they produce a lot of urine, and they're quite hungry, quite hungry. There's significant weight loss, not over several days, but generally 7 to 10 days. Usually by the second week, they're quite skinny, actually, about as skinny as the individual that was in that first slide. They're dehydrated. They also have an electrolyte disturbance. Electrolytes are essentially teeny tiny particles that float around in our bloodstreams, and they pretty much help out with all bodily functions. Salt, actually, is one of them. Ketoacidosis, that's really the worst case scenario for a type 1 diabetic when it comes to disease management. Ketoacidosis is something we do not want to occur only because it's quite difficult to return them back to their normal state. Usually we lose them, even with intensive therapy. Interventions, long-term. Insulin therapy. These individuals are poking themselves with insulin. Dietary modification, which is pretty much general. Lay term speaking, more fruits, well, in moderation, high fiber content, and high protein content, as opposed to starches, so like breads, pasta, cheese, you know, and exercise regimentation. Again, fancy words which mean don't sit around. They have to get up and get moving. So the whole idea in any type of diabetes is tight glycemic control, which essentially means keeping your blood sugars within a normal range as possible. Well, we can skip that. Type 2 diabetes. This is my fourth favorite disease. So here we have Joe Sixpack, clearly. Yeah, so what happens with Mr. Sixpack? This individual produces insulin, so there's insulin in the bloodstream. But what's quite interesting is that the insulin disallows for sugar. The insulin, in a sense, isn't strong enough to allow sugar to be used appropriately. So what happens? The pancreas produces more insulin, which allows the sugar to be used somewhat effectively. The only problem is insulin also has a propensity, which is a fancy term for making something do something, to increase fat cells. And not just increase them in number, but increase them in size. Case in point, Mr. Joe. Very often type 2 diabetics are obese. They may be overweight, depending on whether or not they're exercising, whether or not they're sticking to their diet, and whether or not they're taking their medications accordingly. I mean, these are all things that play in hand. Quite rarely you'll see the non-obese diabetic. More often than not, they're athletes. Yeah, you'll have diabetic athletes. But again, they're quite rare, few and far in between, as they say. Type 2 diabetes. Symptoms. Pretty much the same as type 1 diabetes. The main difference, truly, and classically speaking, is that the type 1 diabetic is skinnier, and type 2 diabetic is heavier. What's quite interesting with type 2 diabetics, especially in the female population, is that they'll have manilial diseases or manilial infections more often than not. Yeast infections, we all know it. Not so much in the male population. There are several predisposing factors, for example, poor hygiene, But, you know, let's not go into that. Also, with type 2 diabetics, which can also happen with type 1 diabetics, but more often than not with type 2, they have blurred vision, mainly because there's such a high sugar content that the nerves in the eyes become damaged. And again, interventions, diet, exercise, medications. You know, as a side note, there was one individual that I knew who had pre-diabetes, which essentially means that his blood sugar was high for a certain amount of time, but it wasn't high enough in order to deem a medical diagnosis of diabetes. He started to exercise, completely changed his diet. He lost about 50 pounds. And guess what? No more pre-diabetes. So it says something. Okay. Medical nutrition therapy. Fancy term that fancy clinicians came up with. It essentially means eating the right things. What does that mean? All that means is eating in moderation. More often than not, we're all eating the wrong thing. So the best thing for any of us to do, if we have the means, as they say, is to visit with a nutritionist or medical doctor. They usually know what they're talking about. And again, the main idea here is lots of vegetables. So if you can see in the center, imagine that is your plate. Half of the plate is covered in vegetables. Doesn't really matter what kind of vegetables, as long as they're vegetables. No, I'm sorry, I take that back. There are vegetables that are more nutritious than others, but here or there, same as everywhere. A quarter of the plate is filled with starch, and again, when we talk about starch, we talk about complex starch. Whole wheat pasta, a whole wheat bagel, well, in this case, a quarter of a whole wheat bagel, a whole wheat slice of bread, anything whole wheat, complex carbs. That's the idea. And protein. Protein, meat, lean meats, not fatty meats. Everybody likes a cheeseburger, but nobody wants to eat one. Forget it. Oh, good. Okay, every once in a while, that's okay. Okay, insulin therapy. So far, we have not been able to come up with an insulin pill. So what we do, we deliver insulin with a teeny tiny needle. Sometimes it's a pen, which is quite deceiving because there's still a needle in that pen. As you can see, in the hospital setting, more often than not, in the top right-hand corner, we'll use something called an insulin pen. Just as an FYI, if you want to sound fancy, you know, you can ask your friends, hey, is that an insulin pen you're using? And they'll say, yes, how did you know? Your answer could be, insulin pens have the orange cap. Okay. Anyway, so that's insulin. Oral medications. These are always fun. So, let's say I'm 16 years old and I'm diagnosed with diabetes. They may start me on one medication. Usually it's metformin or glucophage. But in any case, as we get older, the pill count increases. More often than not, insulin has a role as well. This can become quite costly. Essentially, this is what I was talking about. Diabetes management is quite expensive because it essentially progresses and degenerates our body more and more almost every single year. It's quite scary. This is Uncle Joe. I really like Uncle Joe because Uncle Joe is a diabetic. Uncle Joe is clearly having a heart attack. Well, maybe not a heart attack, maybe he's just having chest pain after plowing some snow. But the idea is, diabetics, more often than not, suffer from a condition called atherosclerosis, also another favorite of mine, which essentially is a deposition or fat gets deposited into our blood vessels. So more often than not, what happens is these diabetics, they have a heart attack, and they develop something called congestive heart failure, my first favorite. But I don't want to bore you with that. In any case, heart disease is quite prevalent amongst diabetics. Strokes. You might have heard the term brain attack, brain infarct. Essentially what happens is a portion of the brain dies because a clot forms. Now, what's interesting, diabetics, besides having a high sugar content of the blood, they also tend to develop a high cholesterol, or better yet, let's just use the umbrella term, fat content of the blood. And what happens is, between the increased fat content, between the atherosclerosis, thrombi form. A thrombus, essentially, if you like to think of it in lay terms, is a clot. It's just a clot. By itself, it doesn't do anything. But when it enters places where it's not supposed to be, it causes a lot of damage. Actually, there was a patient that I had several weeks ago. He had a stroke. He was a diabetic. He actually had two heart attacks prior to. His entire left side was paralyzed for life. You know, there was no way out of it. You know, we had to intubate him. But, you know, neither here nor there. Diabetic retinopathy. Diabetic referring to diabetes, retinopathy referring to disease process of the retina. The retina essentially is the inner lining of our eye. I mean, it might be quite hard to picture, but essentially your eye becomes so degenerated where vision is lost, and essentially more often than not the individuals become blind. This is irreversible in most cases, irreversible. Unless you're young, you know, resilience tends to be a little higher prior to 22. Diabetic nephropathy. The kidney you see to the right is a fairly healthy diabetic kidney. Actually, that's a kidney of a 23-year-old individual. He died in a car crash. Later we found out that he had diabetes. But if you can see the center portions, that's essentially damage from the high sugar content. So in any case, your kidneys shut down at a certain point because they're so damaged. So they can't process your wastes. So what happens is you have a dialysis party and you get all your diabetic friends and you go to a dialysis center and you sit in these comfy looking chairs, you give them your arm, they stick a couple of needles in there and they start transfusing you, which essentially means they'll exchange your blood through several filters, clean it up, and pump it right back into you. This isn't really the lifestyle, this isn't really a modality that saves the individual from death. Death is usually imminent, within a few years, and again, the older you are, the less chance you have. Diabetic neuropathy. Yes, this is a nice one. Quite gorish to look at, actually, in real life. On the picture, it's not that bad. Very often, it has a quite unpleasant odor. So what happens is, yeah, take it in. What happens is the sugar molecules. Again, this is all very lay. It's significantly more complex than the way I'm portraying it. But the sugar molecules, think of them as teeny tiny crystals, what they are. And they're essentially cutting or scratching or mechanically damaging all portions of our body, including our nerves. And more often than not, what happens is with these diabetics, their feet lose all sensation. There was actually a patient that came in 2 weeks ago. We knew nothing of him. He had a car accident. He came to the floor. We were doing our initial assessment, and we found a needle that was in his foot. They missed it in the ER because he came in as a trauma. But 2 days later, well, the needle was taken out and all that. There was a massive infection that formed, and essentially his right foot, imagine the right foot right there, it became black, and it was quite terrible, quite terrible. We actually moved him up to the intensive care unit. So that's really it. The whole idea is, you know, management of your lifestyle. Don't sit around, move around. You ever hear that? Probably not, but in any case, don't sit around, move around. Try to eat as healthy as possible. I know it's quite difficult, especially being college students. Who has time to plan anything? Oh, well, that's the end of the slide show. Does anyone have any questions with regard to anything? Yeah.
Diabetes doesn't change the size of the pupil.
I'm sorry?
Diabetes doesn't change the size of the pupil.
No, it doesn't. Actually, the pupil size isn't dictated by diabetes. It's dictated by certain muscle strands that we have within our eyeball, which react secondary to any sort of impulses we receive. For example, when I look at a bright light, our pupils become teeny tiny. When we turn off the lights, our pupils increase in size. I'm getting complicated. To answer your question, no. Diabetes does not change the size of your pupils. Ah, okay, okay. Yes?
Can you exceed the emotional diabetes? For example, if someone will be diagnostic with diabetes, will be by emotional. For example, is type 1 is for family, right?
Yeah.
But number 2 is maybe for obesity. But this person didn't have neither 1, neither 2, right? So will be emotional diabetes?
There's no medical diagnosis of emotional diabetes, but when we become emotional, our hormones or our kidneys begin to produce hormones. So what happens? Blood sugar goes up. So yeah, sure, I guess technically you can say that there is an emotional diabetic state. So to answer the question, yes.
One more, and then we have to have our next presenter.
You say that sugar causes the diabetes. How about the aspirin, Diet Coke or something? Use kind of sugars?
There is evidence that sugar substitutes do not increase blood sugars. But again, sugar substitutes have only been around for about 40 years, 35 to 40 years. There isn't an extensive amount of research with regard to longitudinal studies. So there's no real way of proving that diabetic or diet drinks don't increase your blood sugar in the long term. But yeah, if you have a bottle of Coke as opposed to a bottle of Diet Coke, the bottle of Diet Coke theoretically will not increase your blood sugar. Okay.
All right. We're going to say thank you.
Oh, yes. Thank you very much. Okay.
Yeah. If you have more questions for Simon, specifically about diabetes, give them to me and I'll send him a big email, okay? And then he'll get back to you the same way. I'm just decided that, by the way. Okay, so Professor Tarasco, and I'm going to ask for your patience. If we have to extend this a few minutes past 10:30, we will. This is a very important topic as well. And, we had a very long presentation about diabetes, and please give her your attention. We will not rush and leave at 10:30 if she is still giving her presentation and you still have questions.
Thank you and welcome. I just wanted to ask the group, how many of you out there are definitely considering going into the nursing career? How many of you are very interested? How many of you are considering it maybe as one of your options? Some of you. And how many of you have no intention or interest in becoming a nurse? Okay, it's a very mixed group. But you know what? Those of you in that last group may change your mind as you move along in your education. I'll tell you a little bit about myself and why I chose nursing. I was like many of you. When I came to this country, I didn't speak a word of English. When I started school, I didn't speak a word of English. English was actually my third language. And I remember all the struggles that I had going through education and not having resources to get me into college. I actually had to go to a city university because that's all I could afford. And I went through that and continued my education and went on to get my master's degree and then a specialty. I specialize in psychiatric nursing. And the reason that I chose nursing was, and it wasn't something I thought about at first. I was studying liberal arts. I just started working in a doctor's office, and I started interacting with patients and people who were in crisis and families and children. And I got to really like what I was doing, and I felt that this is the direction that I wanted to go in. And that's when I transferred from Queens College to Hunter College to complete my degree in nursing. I've never, ever regretted that decision. And that's because there is so much satisfaction, and I'm sure Simon, who, by the way, was a student of mine a couple of years ago, would agree that it is one profession that you always feel satisfied at the end of the day that you have helped someone. And many times it's someone in a crisis. I love nursing also besides the interaction with people and helping. It's an area, a career, where there are so many different options. Simon works in a hospital. I worked in a hospital years ago. I also worked in outpatient facilities and clinics and did therapy outpatient. There are so many opportunities in the community, visiting nurse service, working in doctor's offices and surgical suites. It really depends on what your interests are. And you can specialize. You can decide, well, I love working with children. I want to be a pediatric nurse. Or I love working in labor and delivery and seeing babies being delivered. Or I love old people and I want to work in a nursing home or specialize in geriatrics. So there's a wide range of different options that are available depending on what you're drawn to. The other great thing about nursing as a career is you can pick when you want to work. You know, most jobs, 9 to 5, Monday through Friday. Nursing, you can work days, evenings, nights. You can work per diem once a day and go to different hospitals and not be connected to any one in particular. You can do overseas nursing. You can work as a nurse in the military and be a lieutenant when you sign up for that. So the options in nursing as a career are tremendous. And we're finding that more and more men are coming into the profession. I know when I started teaching here, we had about 5% that were males. We are now up to about 20%. Okay, so I think that the interest in nursing is growing, and the career options, the job opportunities available in nursing is growing. Our population is getting older. We're going to require more nurses. So it's a great career opportunity. And I've been teaching here in this college for over 25 years. And I just love the program. It's very dynamic. It's very intense. I'll tell you a little bit about it, and I can answer any questions you have about the program. Okay, so the nursing program itself consists of both lecture and lab. Okay, so for 2 years, students are generally in the hospital for 2 days, and then they're at campus for 2 days of lecture. And you have to pass both clinical, be safe in the clinical area, and you have to pass your lecture with at least a C, which is 74. Okay, we rotate through different areas. A lot of it is on medical surgical floors, but we also go through pediatrics, obstetrics, psychiatry, community, pediatrics. So you get a taste of all the different areas of nursing. Prior to ever getting into the program, there's a lot that you need to know about how do you get in the first place. Okay, because it is very competitive. There's a lot of people who want to come into the program, and we only have a limited number of seats. So we have to look at each application individually. So when you come to us, we look at your academic program, we look at how you did in the nursing pre-sequence, and we look at how did you do in your PACS test, which is a test that's given here, which kind of looks at general knowledge of science, of math, of reading comprehension. So we look at the overall score in that. And then an admissions committee composed of nursing faculty look at every individual and determine who will most probably succeed in the nursing program, given that it is so intense. Okay, so I don't know if you know about the pre-nursing sequence. Those are 4 courses that you need to take prior to your application and have an actual grade for. And that is English 101, Psychology, Anatomy and Physiology 1, and Math 119. Okay, so why do you think you need English 101, which is composition? What does that have to do with nursing? What do you think that's so important for people who are in nursing? Why is composition so important? Yes, back there? Yes? Oh, I thought you were raising your hand. Yep. You need understanding of the patients. Yep. So you need comprehension and composition to understand the nursing curriculum. Okay, and you also, as you progress through the nursing program and working in the hospital, you need to be able to document, because documentation is a legal, it's legal document. So you have to know how to accurately write. So composition is something that we really stress throughout the program. What about math? Why is that important in nursing? That's an easy one, right? Math? What do nurses do? One of the major roles of nursing is what? Medications? Yes. You're giving medications, And if you don't calculate the right dosage and you're off by 1 decimal or a fraction, you could kill the patient. So we stress math skills, and we do that throughout the program, that you have to know what you're doing with dosage calculations. Why is psychology important? Yes? To understand the patients, yep. To understand their behavior, to understand some therapeutic communication, what's going on with them in their life. Because psychology is part of the health picture and the wellness picture. And then, of course, there's anatomy and physiology 1, right? And I think you all realize why that's important, right? Simon, when he did his presentation, he had anatomy and physiology up there. Okay, how do you treat a patient with a cardiac disease if you don't know how the circulatory system works? Okay, how do you know what kind of interventions work and how they work on the body unless you have a sense of that anatomy and physiology? So that's very stressed throughout the nursing program. And I'm telling you that because as you're taking those pre-nursing sequence courses, they are extremely important and they help to succeed in the program. And that's why we require a high average in those courses. Okay, so our minimum GPA requirement for those 4 courses is a 3.0, which is a B. Doesn't mean you have to have a B in every course, but the minimum is that the average of those courses is a B. Okay, we also look at the PACS, and the higher your PACS score, the better you may be able to succeed in the program. So we look at that as well. Okay, so those are all the admission criteria. We also meet with the students. We make sure that students entering into the program are able to communicate with their patients, with the doctors, with the nurses, because they're in the hospital. And they have to be able to also be safe in communicating. Okay, so that's like the general picture of how to get into the nursing program. We accept students every semester. We have an evening program, which begins only in the fall. The day program begins in the fall and the spring. And it's basically, once you get into the program, it's 2 years. Okay, so you got to take the pre-nursing sequence, and then you take the nursing. Okay, a lot of our students take all of the rest of the courses and then apply for the nursing program, because it is very intense once you get in. I know you use that word intense a lot, but Simon, would you agree that is there any other word that comes to mind? Yeah, it's like you live and breathe nursing when you're here. But then you graduate, and there's jobs available. We encourage all of our graduates now to apply for a bachelor's degree program, because some of the hospitals are requiring that. So that's the direction that nursing is going into. It's a bachelor's degree. And we have a couple of dual joint degree programs where some of our students are enrolled both in nursing and also in York or in Hunter. So then you seamlessly keep going and you get a bachelor's degree at Hunter or York. Of course, there's other colleges around too. Okay, so that's kind of an overall view of the program. I'm not sure what else you would like to know about it, but I'd be happy to answer any questions that you may have. We have a few minutes. So anybody have any more specific questions about the program or nursing? Yes? Sure. I really can someone, I can't really hear you from here. Oh, a Chinese degree into a degree that we have nothing to do with that. You'd have to go to the New York State Nursing Association. I don't know. We don't really review that on this campus. It's really people who are just coming in for reviewing. Yeah. Yeah, but we don't deal with that. Yeah. Yeah, we do look at transfer credits from other countries in the registrar's office. The nursing department doesn't look at that, but registrar does. Any other questions? No?
What's the highest nursing salary you've ever heard of? Even if you didn't.
The highest, well, actually, the beginning nursing salary, and Simon, you could correct me, an associate degree nurse graduating from this program, I would say about 65,000 to 70 is about average. That's beginning. That's with a 2-year degree. As you go up and get your bachelor's, you make a little more. You get your master's, you get more. And then you can also teach with a master's degree or a PhD degree. A lot of the nurses working in hospitals make over 100,000. So it's very lucrative, especially in terms of a 2-year degree. There's not too many associate degrees that can offer that kind of salary. Any other questions? Okay, well, thank you. And I hope to see some of you in the future.